Starting this lecture, I don't know if all of you have a stroke service in your hospital. So we will start as we don't know anything about this topic. We will start with some definition to build our knowledge together, block by block, until we reach the biggest part is how we manage stroke and what is the predictors to admit to the ICU, and during ICU admission, what should we do to these patients. So starting, we will talk about stroke epidemiology and definition, some neuroanatomy and neurophysiology that all of you hates, etiology of ischemic stroke, acute ischemic stroke management, who should go to the ICU, and what is the role of ICU in acute ischemic stroke management. So definition, we will go through a couple of definitions. So usually you'll hear TIA. So what is TIA? It is a transient ischemic attack. Yes, previously it was defined as a neurological deficit that lasts less than 24 hours. Currently, the definition is depending on or radiology based. So it is a transient episode of a neurological deficit that either involve the brain, spinal cord, or retina without counterpart in the MRI. Another definition we will go, sometimes you hear somebody say it's minor stroke. Minor stroke is any stroke that the severity of a stroke is equal or less than 4 in an IH score. Disabling stroke is any stroke that could be less than 4, but it involves an area or a function that is very important for that patient. For example, if you are a singer and you have aphasia, maybe it's in an IH score, it's 2 or 3. So it is minor stroke by the grade, by the severity, but it is disabling because it affects the patient's career. If you are a piano player and you have hemiparesis, yes, it affects your career. If you have hemianopia and you are a driver, yes, hemianopia will account only for 1 in an IH score. And if it is there, it will be disabling for a driver. So it will be a disabling stroke rather than minor stroke. This definition helps us in the management or triaging of our patient. If I can give TBA for a stroke that is minor or not. If it is minor stroke, but affecting a vital function for that patient, allowed by guidelines to give IV TBA. In IH score, it is the National Institute of Health score stroke scale, and it's an 11-element scale, and the severity score, the stroke score severity according to this NIH score, if it is 0, there is no stroke symptoms. If it is 1 to 4, it is minor stroke, as we mentioned. From 5 to 15, it is moderate stroke. From 16 to 20, it is moderate to severe stroke. And if it is more than 21, it is severe malignant infarct. And this NIH score is more representative for the anterior hemisphere, and it is more representative in the anterior hemisphere for the left hemisphere. It is usually underestimate the right hemispheric stroke and the posterior circulation, yes, but it is feasible to use it. So this is about some definition that we will use during this lecture, and I hope that you get them. So minor stroke, it is any stroke that with an IH score less than 4, and TIA, it is an imaging-based diagnosis, and the disabling stroke is depending on the patient's the function fatality for that patient. So we know that a stroke is either ischemic or hemorrhagic, and the hemorrhagic, it has 2 parts, either ICH or subarachnoid hemorrhage. Both are non-traumatic. The ischemic stroke composed more than 85 from the stroke, and the rest is either hemorrhage, ICH or subarachnoid hemorrhage. The ischemic stroke, if we talk about the stroke epidemiology, we have to know a couple of figures that is important and reflecting the how stroke is common. Stroke is the 5th leading cause of disability worldwide. In each 40 seconds, we have one person in this globe will have a stroke, and each 4 minutes, there's one patient who will die because of either a stroke or its complication. So that's the epidemiology of a stroke. And after that, we'll say we will have a couple of information about neuroanatomy and neurophysiology. I should put slide share, yeah. Neuroanatomy and neurophysiology. You know, all of us know that the blood supply of the brain coming from the arch of aorta, we have anterior circulation and posterior circulation. We have three main arteries that's coming from the arch of aorta. I'm sorry, that came from the arch of aorta. We have the innominate artery, which is brachiocephalic in the right, and the internal, common carotid in the left with the left subclavian. They will go and they will branch later on. The the common carotid from both sides will divide in the vertebral four to internal and external carotid. The external carotid will supply the neck and the face, and the internal carotid will go to the brain. And it will divide later on to MCA, which is the middle cerebral artery, and ACA. And the posterior circulation is predominantly formed from the vertebral arteries that will join to form the basilar, and then the basilar will branch. And we will have the circle of Willis. This is a nice circuit. This nice circuit, you will find it only in 30% of population, like what's mentioned in the box. Others has variation, and the variation more than the usual anatomy. This is very important because it correlates with your clinical finding and correlates with the radiological finding, and it puts guidelines for your management later on. So from the neuroanatomy, the blood supply, we will have this. And the very important slide is the middle slide, because it will represent what you will see in the CT scan. The ACAs will supply the anterior part, the red things that you will see it in the CT, in the this diagram. The yellow part that is in these three images, it is the MCA. You see the MCA is supplying big part of the brain. That's why when we see an MCA stroke, it is like a heart attack for us. It is a brain attack. It is the alarming thing. MCA stroke are unforgivable to miss them or not treat them, especially when they come within the window of IV, TBA, or a thrombectomy, because it is the functionality of a brain there, and the fatality rate later is high if we leave the patient without a treatment. So MCA, in summary, MCA will supply your language area in the dominant hemisphere. So in language area and more of your motor function in the right, in the contralateral side. So if you have MCA stroke, you will be, if the patient has MCA stroke, he will be aphasic, and you will have contralateral side, which is right-sided weakness, upper limb more than the lower limb. If the patient has ACA stroke, the lower limb will be involved more than the upper extremities. BCA usually involving the posterior part or the occipital part, which is your site, or your site center, so the patient will be blind. BICA, patient will have more of bulbar dysfunction, which is dysarthria, and they have dysphagia, they have drooling, and these patients will kind to go for intubation immediately, and they will have autonomic disturbance also. Basilar, the patient, when they have the basilar stroke, they will come sometimes comatose. If they are late earlier, they will have a couple of the finding in cranial nerve. If you detect them earlier, thrombectomy will help them and they will recover. So this is the basic anatomy and the basic physiology of the brain. You have to know the brain, the cerebral circulation is a low resistance circulation rather than high resistance circulation as other parts of our body. Stroke etiology. We call it the classification of stroke etiology. We have 4 types. We have cardioembolic stroke, which is the most common. We have the small vessels disease, large vessel disease, undetermined, other determined, and undetermined. The most common cause is the cardioembolic, followed by the small vessels disease, then the large vessels disease. What we mean by cardioembolic is either AFib, LV thrombus, or they have aortic valve abnormalities, infective endocarditis, all PFO, all of these are under the cardiac. And small vessels disease, if the patient have comorbidities like hypertension, diabetes, they are heavy smokers, these are the causes of small vessel disease. Atherosclerosis, we have like internal carotid stenosis, internal carotid atheromatous plaque, and all of this, and this is related to also atherosclerotic process. Other determined these like vasculitis and coagulopathies, and determined you do all the workup and you didn't find anything. So that's we conclude the basic of the stroke. So we covered some in definition, we covered the anatomy of the brain, we covered the etiologies of a stroke, and we will go right now in the management of a stroke. So any management in life of anything, we should have a principle of this management, and the principle of a stroke care, acute care, is to achieve timely recanalization of the artery and reperfusion of the ischemic tissue. That's first. You have to optimize the collateral flow and avoid secondary injuries. This is the blueprint of anything in urology. In the blueprint of anything in urology, you have to reverse the primary injury and you have to prevent the secondary injury. That's it. So if you tackle the primary issue and prevent the secondary complication, your patient will have a great outcome later on, if God will. But if you didn't treat the primary and you let the secondary play, so your patient will have a dismal outcome, patient may die. So these are the principles of acute stroke management. So how can I achieve a timely recanalization of an occluded artery? This either by something that dissolves the thrombus or some procedure that open the artery. So to achieve the recanalization of the artery, I have two ways: either medication that dissolve the thrombus like alteplase, or which is IV recombinant tissue plasminogen activator, or something that opened the artery from within, like a mechanical thrombectomy. These two things should be done in timely appropriate fashion. What means that timely appropriate fashion? That means, especially in IVTBA, we have a time window from 3 to 4.5 hours, depending on which preference. American Heart Association extending the timeline to 4.5 hours, yes. So within the 4.5 hours, I have to use the IVTBA if the patient have no other contraindication. Mechanical thrombectomy, we will go right now and we will see how to progress over the years to reach 24-hour if there is penumbra or tissue to save. So we will talk about IVTBA. IVTBA, it was very well known since 1995 October. It passed through different trials, and the base of all these trials is the ACAS3 when they because it goes ups and downs. There is benefit, there is no benefit, there is harm, there is slightly benefit, there is no benefit, no difference. And the ECAS3 put the ground of everything, and they said there is benefit in the functional outcome for patients who receive IVTBA. The dose of IVTBA, if you go to other medical issues that we use IVTBA, you will see variation of the dose that we use in stroke. In stroke, we use 0.9 milligram per kg, and the maximum dose that we use is 90 milligram. We don't use 1.1, we don't use an infusion of 100. No, we use only 0.9 and the maximum 90. Whatever your weight, after 100, you will receive 90 only. Okay, and depending in the NINDS trial, which is the first trial, the benefits of IVTBA, there will be a good functional outcome in 1/3 of patients. Like you see in this diagram, we have 100 patients. The dark green, they have normal or really normal outcome. The light green, they have better outcome. So like about 30% of these 100 patients, we have good outcome. We will have severely disabled one. 2, they have worse outcome, and we have 3 with we have 5 up to 6 to 5 with with ICH or hemorrhagic transformation because of IVTBA. The benefit of the IVTBA is time dependent, and we have to know this. And if the earlier, the better. And the later, the there will be an effect and there will be complication also. So if you start earlier, it's time dependent. If you start earlier, the number needed to treat will be less. Like if you start within 90 minutes, then the number needed to treat is 3.6. Like you'll treat up to 4 patients and 1 patient will have the normal or near normal outcome. From 90 to 80 minutes, 180 minutes, we will have, you will treat up to 4.3, let's say 5 patients, 2 will have 1 patient will be treated with good outcome. And if you go from 3.3 to 4.5 hours, number needed to treat will be 6. So that show you that your management is time dependent. The more time you waste, the worst outcome you will have. So ultimately, we know there is indication and contraindication. The contraindication, there is an absolute contraindication and relative contraindication, and these contraindications, they are right now shortened. They are decreasing in numbers each year. The American Heart Association trying to drop a couple of the contraindication to allow more patients to go within the IVTBA. So the indication of it's any patient who is diagnosed clinically to have a stroke and the age is more than 18. So it is contraindicated to be used in a children who is less than 18. If the symptoms within 4.5 hours, wake up stroke if there is diffusion flare mismatch. And we will go this with the down trial and diffuse trial. And as I mentioned, if the patient is more than 18. This is the left side of the table, the American Heart Association. Contraindication, severe head trauma, more than 3 months. Ischemic stroke within 3 months. And right now, the last time they said 1 month is acceptable to give IVTBA. And if you go to the FDA approved, it's already removed. Previous intracranial hemorrhage is a contraindication. Suspected subarachnoid hemorrhage is a relative contraindication, but it is a contraindication. Infective endocarditis is a contraindication. Dissecting aortic arch is a contraindication. Recent intracranial or intraspinal surgeries within 3 months is a contraindication. Intracranial intraaxial tumor is not extraaxial. Like meningioma is not a contraindication to give IVTBA, but GBM is a contraindication to give IVTBA. Gastrointestinal malignancy or gastrointestinal bleeding within the last 21 days are contraindication. Active internal bleeding is a contraindication. Systolic blood pressure, if you tried hardly and you cannot manage it, less than 185 and the diastolic is less than 110, you cannot give IVTBA because the risk of hemorrhagic transformation is high. If you cannot, you do your PES and you give even nitroglycerin and nitroglycerin and the blood pressure is not dropping, this is a contraindication. Bleeding diathesis, and this is depending on BTT platelet count. If the patient receiving heparin, it will be therapeutic heparin or therapeutic clexane, and within the last 48 hours, and the BTT is abnormal. Platelet count less than 100, and the current use of direct thrombin or factor 10 inhibitors with abnormal coagulation. If it is abnormal, if the coagulation are normal, let us put it that the coagulation are normal, all coagulation like BTT, BT, eccrine, coagulation time, all of this, and platelet count is not, INR is normal, you can give IVTBA even if the patient is receiving any one of the novel anticoagulation. INR, by the way, if your patient is within the window of 0 to 3, the INR less than 1.7 is, you can go and give IVTBA. But if your patient is within the extension window 3 to 4.5, you cannot give IVTBA, whatever their INR. CT showing hemorrhage, so it is absolutely contraindication. CT showing an extensive, well-established ischemic stroke, you cannot give IVTBA. So by way, anything in the brain within 3 months, anything outside the brain within 21 days, like bleeding, surgery, I cannot give IVTBA. if patient on anticoagulation, if it is warfarin, the INR is less than 1.7, and I am in the window of 3 hours, I will give IVTBA. In the extension, I will not. If the patient on NOACs like dabigatran, apixaban, rivaroxaban, and they're all and their coagulation profile crystal clear normal, even with a creatine coagulation time, I will give IVTBA. If there is abnormality, I will not give. CT showing hemorrhage or big stroke, we will not give IVTBA, and the indication if there is patient with clinical stroke, his age is more than 18 or more. If there is any medication other than Alteplase in the market, yes, but still it's not approved by the American Heart Association for the use, but there's still trials on it, and it is tenecteplase. Tenecteplase, initially it was by the Norwegian trial. They try to compare between IVTBA and Alteplase. Their problem, their study was superior trial, so it was not superior. If they do it, so they didn't report it. And the other trial was also extended trial. Extended trial compared between IVTBA and tenecteplase, and tenecteplase was superior than IVTBA in opening of the proximal arteries, proximal occlusions. So tenecteplase still in the trials, maybe in the couple 2 to 3 years will be in the market to replace all IVTBA. If you see here, this is extend trial 2, and they compare 2 doses of tenecteplase. Tenecteplase, the doses we have 0.25, and the maximum dose is 25 milligram, and the other dose is 0.4 milligram, and the maximum dose is 40 milligram. These doses are equivalent in their effect, and tenecteplase is superior than alteplase in opening of the arteries. So that's conclude the IVTBA. So IVTBA, we have to know a couple of things, that the number needed to treat is depending on the time. The earlier, the lower number needed to treat and the better outcome. The later, the higher number needed to treat and the worst outcome. Alteplase half-life, yes, I forgot to mention, half-life of alteplase is 5 minutes, and it will take 36 hours to come out from our circulation through the kidneys, but there is no renal adjusted dose, okay? And we know the indication and the contraindication of IVTBA, and we know there is a medication that could be in the near future replacing IVTBA, which is tenecteplase. So IVTBA, yes, we have IVTBA. So, and we know it's effective, will give a good outcome if we use it within 4.5 hours. So what is the problem with IVTBA? The problem with IVTBA, we have up to 6% hemorrhagic transformation, yes. It will not work properly in the proximal occlusion. So we have about 20% they will open the artery, and 80% they will not open the large vessel occlusion, which is the stem of MCA, the stem of MCA, the internal carotid artery occlusion, they will not open by the alteplase. So we are limited in these 2 situations. And some patients have contraindication of IVTBA. So I have a group of patients that they cannot receive IVTBA, and they will have devastating stroke if I can't do anything for them. So that's come the trials of thrombectomies. Initial trials of thrombectomies was disaster because they were using the stent of the cardiac patient. Now, after that, Meditronics came to provide us with lots of stent retrievals and things getting better with all the companies. So we have right now many stent retrieval, many aspiration catheters, and all of this stuff. So going from Mr. Clean to THRAS, these are the progression of the thrombectomy trials. All of them, if you go to the modifying Rankin score, which is in the second table, and number needed to treat, and the Mr. Clean number needed to treat is 7.1, and the escape 4.2, and the extend IA is 3.2 for 6.1, 6.3, and 9. And after that, they do a meta-analysis and they brought us like 2.4 thrombectomy number needed to treat by thrombectomy is 2.4 to reach a good outcome. So thrombectomy came to bridge some patients and to bridge also IVTBA in the large vessel occlusions. And it gave us a time to deal with patient who is out of the IVTBA window. Initially, if you go, these are 6 hours, 12 hours with the escape, and the others are less than that. So initially it was agreed by the guidelines to be within 6 hours of the ischemic stroke. After that, we have 2 trials that give us the extension of the thrombectomy, which is the down and diffuse. And these are for a group of patients who either wake up with the stroke, like they slept at night at 10, they wake up at, they wake up at 7, and the last seen normal was at 9. So we have an 11 hours, that's passed. We don't know when they infarct. So these studies or these trials help these patients, and their conclusion as you can proceed for a thrombectomy in these patients if they are clinically very disabled, but their CT scan or their MRI is relatively intact, and we have penumbra to save, and these by either MRI perfusion or CT perfusion. In down trials, we have 3 groups, and either patient is fulfilling one of them. In diffuse trials, patient should fill all of these, like the mismatch. The occlusion site, where it's internal carotid or middle cerebral artery with M1 or M2. And these are the large vessel occlusion. Basilar also a large vessel occlusion. By the way, anything that is mentioning right now, the study is all in anterior circulation, but it is reciprocal in the posterior circulation. On the following group, the mismatch on the down trial, group A, anyone more than 80, NIH score more or equal 10, and the infarct size is less than 21. Group B, if they are less than 80, the infarct size is less than 31, and their NIH score equal or more than 10. Group C, less than 80, NIH score more than 20 or equal 20, and the infarct size between 31 and 50. If we go to diffuse 3 trial, the infarct size should be less than 70 and an NIH score more or equal 6. Ratio volume of ischemia, that means penumbra, and the tissue infarction is 1.8 or more. So we have penumbra to save. Absolute volume of penumbra of more than 15, defined by the maximum time, which is more than 6 seconds in rapid system. So that's the bottom line. If there is a mismatch between the clinical and the radiological, and the patient has penumbra to save, and the penumbra volume should be more than 15 centimeter and cc, and the infarct should be less than 70, and patient footing either one of them. Don't take one of here and one of there. Now take if you want to apply, you apply it fully. Diffuse between 6 and 16 hours, and the down trial up to 24 hours. The functional status before the stroke is very important. You don't give IVTBA for a patient who is bedbound. You don't do thrombectomy for a patient who is dependent on others. Their modified Rankin score should be between 0 and 1. That means they are asymptomatic or they have symptoms, but they fully doing their activity before the onset. Okay. So that's we conclude. Yes, who are candidates for IVTBA of thrombectomy? Anyone above the age of 18, the NIH score of 6 or more. Time from onset, so we said within 6 hours. But we have the extension later on up to 24 hours if we imaging correlates. Good pre-stroke functional status, we said the modified Rankin score between 0 and 1. Alberta score more than 6, and we will discuss Alberta score, aspect score, a presence of proximal intracranial occlusion, which is either the ICA, internal carotid determinus occlusion, or the MCA, M1, M2, and we have the basilar in the posterior circulation. You don't omit the basilar from your mind. Keep the basilar in your mind. So now we have the information, so we will apply it in real life. So acute ischemic stroke, I say, since we have TIA, which is a focal neurological deficit that clinically, it will not depend on the 24 hours. We will depend on the radiological correlate. There is a radiological correlate over it. If the patient came to emergency department, seen by the emerge, he had history, like about 10 to 5 minutes ago, he had a weakness. That's completely resolved when he came to emergency department. Clinical examination, NIH score of 0. This patient fulfilling the clinical definition of TIA. This patient should be admitted for workup. Okay, and you have to know your ABCD score, ABCDI right now, because they are depending on the images. So let's go to the other part of this chart. If it is acute ischemia, acute ischemic stroke, if this patient less than 3 hours, within 3 to 4.5 hours, between like 6 hours, and we will see what we will do. If the patient came within 3 hours, is the patient is alteplase candidate? Yes. Is the blood pressure, is there is any contraindication? No, he is candidate for IVTBA. The CT scan, there is no contraindication, no ICH, there is no hypoglycemia, his RBS is more than 40 and less than 400, and the patient all the labs are normal. The blood pressure is more than 185/110. No, so proceed for IVTBA. Yes, lower the blood pressure, give IVTBA. This patient now, does he have large vessel occlusion during your imaging? Yes, large vessel occlusion, he will go for thrombectomy. Okay, no large vessel occlusion, patient will go for either a stroke unit or ICU for observation, for 24-hour observation. If this patient within 3 hours to 4.5 hours, is his IVTBA candidate? No. Okay, no. Is he a candidate for thrombectomy? Yes, he will go for a thrombectomy arm. If he is candidate for a thrombectomy, no, he will go to receive aspirin and a Plavix loading dose. As this patient is within 4.5 hours, is he's a candidate for IVTBA? Yes, we will manage him for IVTBA. If there is any large vessel occlusion, he will go for a thrombectomy. For example, this patient came after the 4.5 hours, and this patient, he is a candidate for, there is a large vessel occlusion in the CTA, so he will go for a thrombectomy. Let us take an imaginary scenario. Patient is in warfarin, okay, and he came with the INR of, he came within the window of 3.5 hours, 3 and 4.5 hours. His INR is 2, okay, and he has a mitral valve, a metallic mitral valve that was replaced, and he is in warfarin, and his INR is 2. So CT scan, no bleed. So by that he is, and the CTA shows MCA stroke, big occlusion, stem. So this patient will go, he is not a candidate for IVTBA whatsoever, and he will go for the arm of thrombectomy. So you have to put this map in your head. It is easy if you think it is like a logarithm, which patient will fit which part. So, and then you have to control your blood pressure. For example, from my side, if the patient came within, because most of the time we cannot differentiate between, like this patient INR is 2 and he's in warfarin. The initial time when they call you the ER, they will say patient in warfarin. You will think about ICH rather ischemic stroke. So we will ask about the blood pressure immediately. And if this patient is coming within the window, like 3 to 4.5 hours, drop the blood pressure. if he is within the window, if he is within the window, 3 and 4 hours, possibly he will be a candidate for IVTB. If he is hemorrhagic, okay, never mind. If he is not hemorrhagic, and he will be a candidate for IVTBA, like if we think the INR is less than 1.7, and he will go for for alteplase, drop the blood pressure immediately. So don't delay things. Don't delay. It is the time is counting right now. From the initial time they come to emergency department, the clock will start tick, 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 tick for you. So, stroke pathway, as American Heart Association, you identified the stroke signs. Patient came to emergency, activated the EMS. Patient presented to emergency department, pre-hospital notification. Patient presented to emergency department should be not the neurologist should be seeing him with 10 minutes. Neurological assessment should be completed with 25 minutes. CT scan should be completed with 25 minutes, and the report should be given within 45 minutes. And the IVTBA should be given within 1 hour. Yes, per guidelines, yes, it is within 1 hour, but you can fasten everything and give the IVTBA within 15 minutes, even if you were not pre-notified. Why? How? If you are really fast, you can take a good history within 2 minutes. And the real history, good history, you have to dig for two things. When the last time patient see normal? When the last time? Is there is any contraindication? Is patient on anticoagulation? Okay, and you will conclude your history and exam very fast, 2 minutes. This is 2 minutes, 2 minutes, or let's say 3 minutes of exam, 2 minutes for history. And you will go. The radiology should be activated by the emerge. You push the patient in the CT. If there is the CT plane CT scan showing no hemorrhage, you have to take the TBA with you from the emergency department to the CT scan and give the alteplase on the CT table. That will conclude 15 minutes, and it is faster, and you will have a monitor there. You will give, at least you give the bolus, which is 10% of the whole volume that you will give. And if then the patient will continue the infusion, patient should be shifted to the ICU or stroke unit, depending in your facility. If the patient, okay, if this is a smooth patient. No, you don't have a smooth patient. Patient came, his GCS was low in the preliminary presentation. So we know any emergency in the life, we have to apply ABCs. So your ABC, IV cannula, oxygen monitors, everything. And you should, if stroke code activated, you should do a couple of things. IV cannula should be placed. Follis catheter should be placed before. You don't wait, okay? If you wait, you have to wait 6 hours over the IVTBA. Okay, you have to obtain a consent. By the way, IVTBA worldwide, there's no need for a consent because it is the standard of care. In our hospital, we have to take, in Saudi Arabia, I think you should take the consent. Obtain consent, check for BT, INR. You can, if you know by history, patient is not taking any anticoagulation and no antiplatelet, no bleeding diathesis, you can give IVTBA without doing them. Yeah, like without waiting for the result. If the patient came, the only thing that you will correct before, two things, yeah, you will correct before giving IVTBA is the blood glucose and the blood pressure. If the blood glucose less than 40, because the symptoms will have the hypoglycemia can cause weakness, you will give IVTBA. You will correct with D50 and see if it is reverse, not reverse. If it is reverse, well and good, no IVTBA. If it is not reverse, that means a stroke and you have to give IVTBA. And you be careful at the contraindication. I didn't mention seizure. Seizures currently are not contraindication for IVTBA, by the way. Treat the seizure and give IVTBA. So seizure, hypoglycemia, blood pressure, treat them and proceed if it is not reversible with hypoglycemia. So blood pressure, it is more than 185 over 110, treat your blood pressure. Suitable treatment is calcium channel beta blocker like labetalol, or if you have hydralazine, whatever you have an IV in your hospital, try to use it. We try to avoid nitroglycerin. We try to avoid like the vasodilator things because they will cause high ICB later on. Obtain the CT scan, and if there is ICH, this patient is not candidate for IVTBA. If there is no and blood pressure is maintained, give IVTBA. The maximum dose is 90. You will divide the doses two part, bolus 10%, and the rest is the infusion. So with the IVTBA vials, each vial is 50. So if you have a patient who weigh 100, you will discard a 10 ml initially. You will give the 9 ml, the 9 milligram bolus, and you will give the rest as infusion. So be careful with the nurses. Discard whatever you will not use initially. Give the bolus and continue the infusion. If anything happen in this, and this is what ICU will be involved in. If anything after the infusion of IVTBA or during the IVTBA infusion, or the patient when he came is bad and worse situation, these are the times that the ICU will be involved. If he needs intubation from the beginning, the ICU will be involved. If anything happen in this, like blood pressure is not controlled and I want to give IVTBA, the patient within the window, the ICU will be involved. And if anything happen, if anything disastrous happen, IVTBA, we know there's possibility of hemorrhagic transformation. IVTBA has a complication. It's not a safe drug. We are use it because we elect to have better outcome later on. So it's safer drug, by the way, it's safer drug, but everything we do it, we have a complication. So if the patient during the infusion start to be sleepy, he starts to vomit, he is disoriented, he is not himself, stop the IVTBA, send labs, and send patient for CT scan. If you see hemorrhage, start cryoprecipitate, tranexamic acid, start everything that can reverse that, and call neurosurgery. Okay? No, he is fine. He is not complaining with that, but all of a sudden he start to have swelling of his lips, and he start to have a stridor. Stop your infusion, give dihydrophenamine, ranitidine, which is now out of the market, dexamethasone, steroids, whatever you can give, and if patient is not improving, proceed for intubation. So these are the tricks that possibly will happen. It's not common to happen, but it happens. So, and if the patient was like a smooth patient, received IVTBA, went for the stroke unit or the ICU, what shall I do with them? So we will observe them in 24 hours. In the first 2 hours, we will check their blood pressure, their neurological examination, the puncture site, like and the peripheral pulses every 15 minutes for 2 hours. Then every half an hour for 6 hours, then every hour for the rest of 16 hours till the next day. Okay. So that's conclude the management. Okay, we will go for imaging because imaging is part of a stroke pathway. So we said if there is the contraindication, if there is a well-established hypodensity. Okay, there is sometimes not well-established hypodensity. There's like blurring of the margin. Can I conclude this as shall I give or shall I not give? It's a gray zone for the junior residents. Yeah, there is changes here. Yes, it's changes, but it is not a clear hypodensity. So the earliest sign of stroke in the plain CT scan are not a contraindication for IVTBA. So hyperdense MCA sign or dot sign in the MCA or other vessels is not a contraindication to give IVTBA. Loss of gray-white matter differentiation is not a contraindication. Hypoattenuation of the lentiform nucleus is not contraindication. And cortical hypodensities within association of parenchymal swelling which is resulting in effacement, are not a contraindication to give IVTBA. So if you look here, you will see here the left MCA is slightly brighter than the left side, and this is not contrasted images. And this is the hyperdense MCA. If you look here, this is more prominent, and this is the right MCA is brighter, and you will see the anatomy here. You see the sylvian fissure is very open and very clear, and here you will see like has been erased, has been scratched, and the The gray-white matter that I see it here, I don't see it here. And this is the earliest sign of a stroke. These are not a contraindication for IVTBA. These signs, they give you the answer. The patient to present with these signs, like within 3 hours, you can swear this is a malignant stroke will turn if I'm not doing anything for this patient. Okay, so this is the earliest sign, hyperdense MC error or dot sign, the effacement, loss of white matter differentiation, and if we go to different cuts, we will say the basal ganglion, which is the lentiform nucleus anatomy, has been lost. Okay. We have 45 minutes only. Aspect score that we mentioned initially, in the CT scan, we have different areas that's supplied by the MCA. And like the caudate, the M1 here, M2, internal capsule, lentiform nucleus, extreme, the insula, M3. These areas, they are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 areas. 10 areas. These 10 areas, if you look at them, these 10 areas, if any infarction or any change in these areas, we will subtract 1 from 10. And that's why when we say aspect score of 5, that means we lost 5 region already has been involved. If aspect score is 4, that means 6 region, and the lower the aspect score, the more your intervention can cause hemorrhagic transformation. And you have to be clear with the patient and the family. There is more liability to have hemorrhagic transformation. The patient will benefit, but there is possibility of hemorrhagic transformation depending on how much your aspect score. Okay, what you see here below this is the CT perfusion. CT perfusion, we will look at it in different cuts, and we will see. This is CT perfusion. We will start with the right because it is more obvious, and the right because it is more obvious. What we will see in the right scan, we will see in the left hemisphere, because this is the right and this is the left. The left hemisphere, we will see here like very dark blue thing. And we will see here some red, bright yellow, bright light blue. This area here is completely infarcted. This is the cerebral blood flow. And it is resembling the cerebral blood volume. They are like twins, same, nothing different between them. There's no mismatch. And this is when we have this picture, this patient is infarcted. No matter what you say, this patient is infarcted. The mean transient time will be high. It is the vice versa of them. And this is infarction. So infarction, if there is mismatch between the CPF and the CBV and the mean transient time, okay, that means there's no mismatch, I'm sorry, between the CPF and the CBV, this already struck patient. Let us see the other side. We have here, if you look carefully, you will have here red area, which is suggested. That means that mean transient time, if you look here, this is the lowest part and goes higher here as the grading. So more than like in 20s or like here in 13th. So this is a prolonged mean transient time. Prolonged mean transient time, that means the contrast will take longer time to reach this area. So anything will take longer time means there is a blockage in the way. Something happened in the way. So when something happened in the way, there's an infarction. There's something included in the vibes. So CBF and CBV, they are they are not almost the same. Like you will see here, dark green, dark blue, but you will not see it here. The CBV is like normal. Here it's like here, but here it's darker. So there is a mismatch between the CBV and the CBF, and that's conclude there is penumbra to save. So which patient will go for intervention? This patient, the left-sided patient, not the right-sided patient. So to conclude, what will happen in a stroke patient and stroke code, the CT scan, patient has no contraindication, CT scan is normal, we go for CTA, he will receive IVTBA. We will do all, by the way, we do all these images together in our hospital, like in one shot. So CT You will take him for the images. He will do all of them. So the CT scan, you review it initially before the CTA or CT perfusion. Nothing there, you give IVTBA, you continue these all together. So don't delay IVTBA for other images. Okay, there is an occlusion here, as you see, and the CT perfusion, there is we don't have other images to conclude if there is a penumbra to save or not, but we don't see here a real infarction. There is occlusion here, there is occlusion here, very prominent, then they open the artery with a thrombectomy. So it's nice. So after that, the patient will be shifted to stroke unit or the ICU. So if patient need intubation or not, okay, that will proceed initially, or there for a thrombectomy patient to proceed for intubation because patient was not cooperative. We don't prefer to do a thrombectomy on general anesthesia. Why? Because after that you will lose patient exam. So the better you local anesthesia or max sedation, and then you wake up the patient. Intubation, if this was complicated by angioedema and all of that stuff, stridor, and we need airway protection, so we will proceed for intubation. We don't give supplemental oxygen except if the saturation is less than to 92. Mechanical ventilation, as what we mentioned, if we need it from the beginning or if we need it later on during a thrombectomy. Fluid management, you will try to give, patient will be MBO in the first 24 hours till you repeat the CT scan and see. Because why we keep them 24 hours? Because we don't know. The hemorrhagic transformation could happen immediately during the infusion or could take the 38 hours later on. So we will give a fluid. We maintain we maintain them euvolemic 2 to 3 liters in the 24 hour. Blood pressure, okay, and this is the strike. We said we will maintain the blood pressure less than like 180 over 105. Yes, this is per guidelines if patients receive IVTBA. And now the problem that we will see if patients receive IVTBA and it was completely canalized or not completely recanalized. Patient goes to thrombectomy, he is completely recanalized or not recanalized. And you will see in the intervention reporting, they say TICI score 2 or 3, 2 to 3. If it is 2 to 3, that means, especially 3, it is good recanalization, like the artery is open up to more than 85. So the blood flow returned to almost normal. And this time, you don't have to keep the blood pressure high, like 180s. And there is a study that I sent it to all of you. I think Hisham read it already, and he know the conclusion that we can keep the patient blood pressure up to less like in 160s. And now that was an observational trial, and they are doing the randomized control trial to see what's the effect. We can use TCD in this and see how is the blood flow and augmentation of blood pressure or not doing anything for blood pressure, and variation of blood pressure will improve the blood flow or not. We can do this. Prophylaxis for DVT, initially in the first 24 hours, they will be in pneumatic boots. After the CT scan, after repeating the CT scan 24 hours, there is no hemorrhagic transformation, you can start DVT prophylaxis, chemical, either Clexane or heparin, whatever you want. Other measure, maintain normothermia, maintain the RBS between 140 and 180. You don't need to keep them in insulin drip. You don't need. According to the SHINE trial, you don't need to keep them on insulin drip. You can use the sub-Q, but the problem with sub-Q, because we have given the IVTBA only. Okay, access you have if you want to put an intra-arterial before arterial line before giving the IVTBA, or wait till you managing their blood pressure without invasive measurement. Okay, so we conclude the management. So we will go to factors that predict the ICU admission. Like, when I saw patient, when we see patients, we say, okay, holy crap, he will go to ICU. Okay, and the other patient will not need ICU. Okay, So how we have this prediction? We have different scales in the stroke patient. We have determination of intensive care after thrombolysis score, and factors increasing the requirement of ICU admission with this stroke patient. In our hospital, the most factors that I saw is the blood pressure management or systolic blood pressure and the NIH score. Age, African American male, hyperglycemia, specified physiological score more than two greater than 22, and vascular disease or patient's renal failure, usually they are a problem also. So these are the factors that we can use to predict who will, in our assessment, in initial assessment, who will go to ICU. And you will see by generalization the two that make patient to go to ICU, the blood pressure and the NIH score. I know there is a question in your heads. Most of all the stroke patients are coming to the ICU. And in the ideal world, not all stroke patients should go to ICU. The ideal world, the stroke patient who receive IV-TBA or thrombectomy without any complication, they have to go to stroke unit. The complicated cases, they have to go to ICU. So this is from like NIH score, age, comorbidities. This is from the other system requirement, patient with cardiac disease, renal failure, as I mentioned. These are systematic indication. Neurological indication, post-thrombectomy patient they have some complication either during the procedure or IV-TBA infusion. Patient develops cerebral edema, or patients have hemorrhagic transformation with the IV-TBA. And hemorrhagic transformation, the IV-TBA, we have 4 types. It happens in up to 6% of patients. We have type 1 hemorrhagic infarction, type 2 hemorrhagic infarction, type 1 parenchymal hematoma, and type 2 parenchymal hematoma. If you see this is a hemorrhagic infarction. You will see here some small petechiae. These are not contraindication. Like if I see it, I will not stop the DVT prophylaxis. I will continue DVT prophylaxis. This also, I will not stop DVT prophylaxis. Here and here, I will stop the DVT prophylaxis. Here, I can give aspirin, but here I will not give aspirin. And all of them, I will not give aspirin. So here, I should be careful to weigh the benefit-risk ratio. If this patient on alteplase, he developed hemorrhagic transformation, I keep them in DVT prophylaxis. I will repeat the scan 24 hours. If there is, after the repeat CT scan 24 hours, there is no progression, I can start at least aspirin, but in these I will not start. Okay. Okay, and the last one will need a surgical evacuation. Okay. So here we have the post-thrombectomy and post-thrombolysis and thrombectomy management, neuromonitoring, hemodynamic management, blood pressure, dysphagia assessment. Yes, the patient need NG tube, don't need NG tube. They are not able to swallow, angioedema, and excess site of hematoma. You have to observe because sometimes your patient will do fine from the thrombectomy in the brain and from the alteplase, but they will have complication at the puncture site, and you have to observe for either the hematoma, or because sometimes they can have pseudoaneurysm at the femoral site, or they will have ischemic limb. So you have to see the pulsation and dorsalis pedis, the oxygen saturation in both lower extremities, checking the puncture site, and this is one of the things that we have to do. Cerebral perfusion control, like blood pressure, we said we have to maintain F with IV-TBA less than 180 over 105, but the guidelines are not now. There's trials try to change this practice, because with this practice, hemorrhagic transformation is much more common, especially if there is complete recanalization. I'm sorry. Hemorrhagic transformation, as we mentioned, we have the two reverse decoagulation with the cryoprecipitate 10 units, platelet transfusion, tranexamic acid, call for neurosurgical evacuation. The reversible of anticoagulation, we will talk about this in the ICH management. Platelet transfusion with antiplatelet, like patient develop hemorrhagic transformation with antiplatelet. We will talk about it later in the next lecture. We don't give platelet except with alteplase. possibly they will go to OR. Brain edema management. If patient develop brain edema, we call it malignant cerebral edema, as manifestation of hemorrhage of hemispheric syndrome, in combination with altered mental status and impending herniation and possible death. And trials, we have 3 trials: Dismal trials, Destiny trials, and Hamlet trials. All of them conclude the pooling of these studies, indicating that performing hemicraniectomy in patients with malignant cerebral edema reduced the mortality by 50% and improved their outcome by 16%. So improving the outcome depending on modified Rankin score. So the modifying Rankin score from 4 to 3 by 1. Patient death apply in patients who are younger than 60. Destiny 2, we have extension for that for patients who are older than 60. They said also there is improvement on their reducing mortality, but the outcome benefit is very minimal and should be happen within 48 hours. Brain edema, as I send you the articles, brain edema management of stroke, either by osmolar therapy or mannitol with decompressive craniectomy. Reminder, during this, we have to search for the etiology of a stroke. Either during the stroke code, it helps us to have the neck imaging if there is any carotid problem. We have to check the cardiac issues. If the young patient who is less than 55, we have to do a thrombophilia workup, hypercoagulable autoimmune disease workup, and we have to do TEE. BFO is one of the previously they call it as cryptogenic because they don't know, they are doing only transthoracic echo without any conclusion about, but now there is 3 studies about closure of BFO, and it's helpful in patient who has no risk factor except for BFO as their etiology for the stroke.